Hello, and thank you for joining today's webinar, Building COVID-19 Vaccine Confidence Before, During, and After Pregnancy. My name is Antonella Pucci, and I'm a project officer for CANVax at the Canadian Public Health Association. It's our pleasure at CANVax to be hosting the Public Health Agency of Canada's webinars on COVID-19 vaccines for healthcare providers. To learn more about this webinar series, please visit our website at canvax.ca in the link you see on the screen. Before we begin, we'd like to acknowledge that the Canadian Public Health Association's office is situated on the ancestral and unceded territory of the Algonquin Anishinaabe people. They have been the guardians of this land for millennia, and we are grateful for the example their stewardship provides. CPHA is committed to working with all First Nations, Inuit, and Métis peoples and their governments in realizing meaningful truth and reconciliation. On to some housekeeping items. The webinar is taking place on Zoom. If you have any questions regarding technical difficulties, please contact canvax@cpha.ca and we will reply to you as soon as we can. If multiple people are experiencing the same problem, we'll address it live via a broadcast message in the chat. That being said, the hosts will use the chat tab for extra communication to participants, so please keep an eye on that as well. For the questions and answers session of this webinar, it will be focusing on today's topic of building COVID-19 vaccine confidence before, during, and after pregnancy. Please submit or upvote your questions for the presenter and the Q&A box at any point during this webinar, and they will be answered at the end of the presentation. Due to time limitations, not all questions can be answered. As for some quick notes, the webinar is being recorded and will be made available on canvax.ca and on CPHA's YouTube channel a few days after the end of this presentation. Presentation slides will also be shared. We would also love to get your feedback, so please fill out our 5-minute post-webinar survey in the evaluation email, and we will be sending it after the webinar. Finally, if you haven't already registered with CANVax or subscribed to our newsletter, visit canvax.ca today to do so. Now I would like to turn the floor over to today's moderator, Stephanie Elliott. Stephanie is a senior policy analyst in vaccine confidence in the Public Health Agency of Canada. She holds a master's degree in public health from Oregon Health Sciences University and is a subject matter expert in vaccine confidence and vaccine science knowledge translation. Stephanie is also a former midwife and an international board certified lactation consultant. Over to you, Stephanie.
Thank you, Antonella. I'd first like to begin by thanking CANVax for their support today, making this webinar possible. Today's presentation is on building vaccine confidence before, during, and after pregnancy. FAC and CANVax have provided a companion webcast summarizing the evidence on COVID-19 and vaccines during pregnancy, during lactation, and related to concerns about fertility and menstruation. We'll not be covering the safety and effectiveness of vaccines during this webinar, nor answering questions on this topic in the Q&A. We recommend viewing the webcast, which will be posted in the chat for up-to-date information on vaccines in this population. And now I'm delighted to introduce and welcome our speakers for today's webinar. Dr. Eve Dubé is a medical anthropologist. She is affiliated with the Quebec National Institute of Public Health and the Department of Anthropology at Laval University. Her research program focuses on the sociocultural determinants of vaccination. She's a lead investigator on of the Social Sciences and Humanities Network of the Canadian Immunization Research Network. And she's interested in understanding how to enhance vaccine acceptance and uptake, and is leading a variety of projects around this issue. Dr. Isabelle Boucorin is a clinical associate professor at the University of Montreal. She graduated from the University of Nice, Sophia Antipoli in France, and after maternal fetal medicine fellowship at the University of Montreal and a fellowship in reproductive infectious diseases at the University of British Columbia, she joined the public health school at the University of Montreal and is the obstetrics and gynecology department of the CHU Saint-Justine, where she's the co-director of Women and Children's Infectious Disease Center, a provincial referral center for congenital infections. She's also a member of the Society of Obstetricians and Gynecologists of Canada's Infectious Diseases Committee. And next slide, please. Here are the disclosures for today's speakers. And next slide, please. Here are the objectives for this webinar. After the webinar, participants will be able to discuss challenges to vaccine confidence for people who are pregnant, considering pregnancy, or lactating, and identify strategies for building vaccine confidence in this population. During this webinar, we'll invite you to participate in some quizzes to test your knowledge and reinforce your learning of these objectives. We'll also be presenting 3 case scenarios discussing a diversity of vaccine confidence challenges. Dr. Bukwaran will be walking you through how you might approach each of these situations to build vaccine confidence in your patients. So without further ado, I will pass it over to you, Dr. Dubé.
Thanks, Stephanie, and thanks, Antonella. I'm really pleased that the slides are working. Otherwise, it would have been a very different presentation. Next slide, please. So first, let's start with defining vaccine hesitancy. And this is the definition that the WHO SAGE working group agreed upon a couple of years ago. So vaccine hesitancy really refers to delay in acceptance or refusal of vaccine despite availability of vaccine services. So it's really focusing more on the demand side of vaccination than the access or supply side. The definition also mentioned that vaccine hesitancy is complex and context specific, varying across time, place, and vaccine. Next slide, please. So really the novelty of this concept when it was brought in the public health domain was to reflect the fact that vaccine acceptance is not a dichotomous decision. It's not whether you're refusing vaccine or accepting vaccine, but it's really on a continuum, ranging from a small minority of people who refuse all vaccine with conviction to the vast majority of people or Canadian who accept all vaccine. In the middle are a heterogeneous group called the vaccine hesitant. So the vaccine hesitant people can still be vaccinated or accept all recommended vaccine, but have important or significant doubts and concerns. And they could also be refusing all vaccine, but be unsure of their decision. And they could accept some, refuse other, or delay vaccination. Next slide. So as noted, vaccine hesitancy is complex and context specific. There's many different factors playing in how people make vaccine decision or to explain why people are vaccine hesitant. But there's this simple model called the 5 C's who summarize all these factors. So the first and major factor is confidence, to refer to people's trust in the safety and efficacy of vaccine, but also trust in the system that's providing the vaccine, in the expert committee who are making vaccine recommendation, in the politicians who are in charge of organizing health system. The other one is complacency, and it could be summarized by the expression that vaccines are a victim of their own successes. It's really to reflect this idea that when vaccine preventable diseases are less prevalent, then people are more focused towards the risk of the vaccine instead of the risk of the disease and can be complacent about vaccination. Constraints refer to issue when vaccine services are organized or convenience. Convenience or constraints refer to how vaccine services are delivered or organized, and that could be barriers in acceptance. For instance, when vaccination services are not culturally adapted. Calculation refers to the individual's engagement in intense information search or risk assessment before making a vaccination decision. And this could be a sign of being risk adverse. And finally, collective responsibility is really this idea that you could make vaccination decision not just to protect yourself, but to protect also others in your community to earn your community immunity. Next slide. So we know that many research around vaccine acceptance or vaccine hesitancy are really focused on the individual levels, the individual knowledge, attitudes, belief, opinion, psychological antecedent, and also socio-demographic characteristic. But this model, that is the social ecological model, is also to show you that while individual attitudes and behavior are important, there's other layer of influence on people's vaccination decision that are important to consider. For instance, what others around us are doing or saying about vaccine, whether or not we receive a recommendation by a trusted healthcare provider, whether we're faced by misinformation online on social media, all of those different layers of factor can influence an individual decision to vaccinate or not. Next slide. And of course, we know that we're facing a pandemic and that COVID-19 can influence vaccine hesitancy or vaccine acceptance. On a positive note, it could make people more aware of the importance of vaccine and the consequences of infectious disease and vaccine preventable diseases. It can make people more aware and knowledgeable about the vaccine development and regulatory process. But it could also make people more worried about different things that were not seen before. There's always been different brands or type of flu vaccine, but nobody was asking which one they were receiving in the campaign. Now we're seeing that people have very, very specific questions about vaccine platform, etc., which is quite new and brought by the pandemic. We also have seen that decision about vaccination could be have become part of an identity, and that for some people refusing vaccine, this could have an important impact in the sense that they're promoting their identity as someone who's refusing vaccine. We also have seen some politicization and increased polarization around vaccination decision that is quite new to the pandemic, at least in Canada. And of course, the change in recommendation could and the impact of the new variants, the Omicron variant on vaccine effectiveness could have had an impact on vaccine hesitancy and vaccine confidence. Next slide. And we also know that pregnancy is a particular state for making vaccine decision. In pregnancy, there's this idea that, or this culture that we should avoid our medication, and although flu vaccine have been recommended for years in pregnancy, they're still perceived as a quite new routine care in the routine follow-up of pregnancy. So there's this idea that you should not eat certain food, you should not do things, and then you should be vaccinated. That play out in how pregnant people can perceive risk of vaccination. There's a lot of risk aversion for imposing anything to the fetus, which make the vaccine decision in pregnancy specific to that context. So we really need to understand the specific context of pregnancy when we address vaccine hesitancy. Next slide. So we don't have good data in Canada on vaccine uptake, but there's different studies in the US that have shown that the uptake for COVID-19 vaccine in pregnancy is around between 74 to 85%, which is quite good in a sense. But when these studies have looked at the determinant of vaccine acceptance, they've shown that the major concern is safety for the pregnant person and the pregnancy and the risk of the fetus and neonate. Among other concerns that are identified in the literature, which are specific to COVID, but were also there for other vaccine in pregnancy, like pertussis. There's vaccine side effect. This idea, this is a kind of a new one. It's been shown for other new vaccine, but this idea that vaccine could cause infertility, doubt about vaccine effectiveness, the belief that there's no need for vaccine in pregnancy, or belief that there's a low risk of COVID or being really sick from COVID. Next slide. So to sum up what I've told so far, key takeaways: so vaccine hesitancy is a continuum. It's not a yes/no decision. There's those who are vaccine hesitant are an heterogeneous group, so there's similar characteristics, but the reason why people hesitate to vaccinate are quite diverse. But the 5C framework can explain the major factors that could lead to vaccine hesitancy. And of course, pregnancy poses specific challenges with regards to vaccine confidence, and a key focus is really around vaccine safety.
Okay, so we've come to our first poll of the day. We invite you to take a moment to answer this question to the best of your ability. Which is not one of the 5 C's of vaccine decision-making: complacency, coercion, confidence, collective responsibility. And I'll just give you a moment there. All right, so the correct answer is coercion, which it looked like most people got. Coercion is not one of the 5 C's. The 5 C's are confidence, complacency, collective responsibility, convenience, and calculation.
Okay. So now moving on to the next part of the presentation on strategies for building vaccine confidence during pregnancy. Next slide. So why is it important to address vaccine confidence? We know that one of the key reasons why someone who is vaccine hesitant finally decide to accept vaccination is after receiving a positive recommendation by a trusted healthcare provider. And we know that especially maternity care providers are well equipped to have vaccine conversation with their patient because they're already trusted and because they have experience with informed choice discussion that are frequent during pregnancy. This is also a specific moment because vaccines are recommended before pregnancy, but also for kids once they're born. So it's a key moment to start building or maintaining vaccine confidence. Next slide. So we will go through each of these strategies more in detail in the coming slide. We will go through this, but the last one is use a culturally appropriate approach, acknowledging the patient unique context, value, and belief. So in terms of listen actively and try to identify where the patient is on the vaccine acceptance continuum. This is a key steps. We know that we don't need to use the same approach whether someone is really vaccine confident and whether someone is really opposed or vaccine resistant, and to identify where the patient is on this continuum, the research or the literature has developed an evidence-informed strategy, which is to start with a presumptive statement, acknowledging that vaccine is the normal thing to do, or that vaccine are recommended. For instance, saying today you're due for your purchases vaccine, or today we can offer COVID-19 vaccine, which is recommended in pregnancy. And then depending on what the patient will answer, you could generally quite easily see whether the patient is really vaccine confident or really not willing to be vaccinated. And often for vaccine hesitant, people will make statements such as, I'm not an anti-vaccine, but I'm not sure, I'll wait for the next visit, or a statement like that. Next slide. And then once you know where the patient is on the continuum, there's different strategies or communication approach in the interaction. For those who are accepting of vaccine, which is often the vast majority of patients, the importance is to address pain and anxiety. That could still be a concern, even though people are vaccine confident, to inform about potential side effects, and to, for other routine vaccine, to set appointment to make sure that the person is able to act on positive intention. For those at the other side of the continuum, the small minority who could be vaccine refuser or firm vaccine refuser, we generally say that the idea is to keep the conversation brief, but to try to keep a door open. Often research has shown that by repeating a recommendation or by having this vaccine conversation a couple of times, that people can move towards acceptance. And really the aim with this group is to build trust, so to maintain the trusting relationship, not to convince to vaccinate. And often these vaccine refusers have gathered a lot of information about vaccination, and they have very specific questions. So the idea is not to argue or share fact, but really to inform about the consequences of not accepting a vaccine and to keep this conversation in other appointment. And for the vaccine hesitant, we've mentioned that vaccine hesitancy is context specific and complex. So really is to listen to try to understand what makes the person ticks. And in that case, or for this group, motivational interviewing is a communication technique that is quite helpful. So it's really to be able to address the specific concern in this one-on-one relationship, and to base the conversation on where the person is. We also recommend to use plain language to avoid scientific jargon, and to have positive stories, your own positive stories about vaccination. It's often more convincing than facts or statistics when you're able to bring your own experience as a provider in the conversation. And next slide. It's important as well to maintain up-to-date knowledge. As noted, some vaccine hesitant or vaccine refuser can have a lot of questions, so it's important to be well equipped to have these conversations. For instance, the webcast that was shared with this with the registration is a good way to have up-to-date information on COVID-19 in pregnancy and vaccine effectiveness and safety during pregnancy, as well as current recommendation for use. We also know that often from a professional view, we use evidence-informed information about vaccination. We're really looking at epidemiological data, data from clinical trials, but we know that people make most this decision based on their emotion. So it's important to trigger the right emotion. And as I noted, to put statistic into context, to explain what that means for the person in front of you, not just in general. We also know that some heuristic or cognitive bias affect how people make decisions, and that there's some ways when we our brain is tricking ourselves. For instance, when risks are shown when risks are shown in a frequency, not in a probabilistic format, it increased risk perception, for instance. And people have really an hard time interpreting probabilities. For instance, 1 in 10, it's feel more risky. You could imagine a person among 10 person versus 10% is quite abstract. It's also important to be aware of common misconception about vaccination, to be able to have some facts or some explanation of why this particular myth is circulating. Next slide. So we also know that during the pandemic, the proportion of false information or disinformation really explode, especially in social media, to a point where WHO was telling that we're not just fighting a pandemic, we're fighting an infodemic, an overabundance of information that make it really difficult for people to find accurate information to make evidence-based decision. And we also know from the research that being exposed to vaccine misinformation has a negative impact on risk perception and vaccine attitudes and decision. Often the first thing we see is what sticks, and it's possible to debunk myths about vaccine, but it's really important to be doing that using a good approach, because if you keep repeating the myth, that's what people will remind, not the explanation why the myth is false. So we sometimes see like in myth debunking pages, the myth is in big bold letter and the explanation is in small text below. That's not a good thing, because people will read only the myth and won't maybe read the explanation, and the myth will stick. And it's also important to fill the gap when you have an explanation of why vaccine don't cause infertility. The causes of infertility are still not explained. So you need to have some other alternative explanation to fill the void that by removing the myth you make. Next slide. So as noted, motivational interviewing is a very helpful technique to address vaccine hesitancy. I'm sure that many healthcare providers are already aware of this technique. It's been developed in the 1970s, and it's really was developed to fight addiction, drug addiction, alcohol addiction, tobacco, but it's been adapted by one of our colleagues for vaccination, and the reference will be shared after the webinar. But really what motivational interviewing is using the person's own motivation for change instead of using your own argument. So it's really a shift from talking to people, trying to convince people, to working with people to change. Next slide. So it's really difficult to summarize in a couple of minutes what is and not motivational interviewing, but I really recommend reading the small papers. But it's based on 4 communication technique, to use open-ended question to really make sure that you listen to the person's concerns and worries about vaccination, to use affirmation. This means not being judgmental, but also showing people strength. For instance, when someone has many doubts about vaccination, many questions, many concerns, you could say something that, oh, you really research about vaccine to make a decision, for instance. Reflexive listening or summaries is another technique that is a bit more difficult to use if you're not trained, but it's to make sure that you've correctly understood what the person told you by reflecting just what's being said or what you think the person meant, what she was saying, what she said. And often it's perceived that motivational interviewing technique is not compatible with giving information or sharing information. It's not exactly true. You could still share information, but there's this particular way to doing it, and it's by elicit, share, elicit. So starting by asking what the person already know on the topic, what the person already know about vaccination in pregnancy, for instance, and then asking permission to share additional knowledge. That's really a way to reduce tension in the conversation. Once the person agree, which is generally the case, then you could share information, and then the step after is to elicit back, so to ensure that what you've told was correctly understood by the person. So for instance, I had this example in another webinar after in the Q&A where someone told me, oh, I did say that, you know, this myth with measles and autism is the, there's no link between measles and autism. And then she was giving some statistics, and then the person, what she reminded was that, oh, there's something with measles vaccine and autism. So you really need to ensure that what you meant to communicate was correctly understood. Next step, next slide, please. So key takeaways on strategies for building vaccine confidence. Mis and disinformation is a significant contributor to vaccine hesitancy, especially during this pandemic. And it's important to debunk myths about vaccine, and there's some good approach to do it. Healthcare providers are really well positioned to build vaccine confidence during pregnancy. And it's important to tailor conversation to the individual, their own concern, and their place on the vaccine acceptance continuum. Motivational interviewing technique is a useful tool, especially for those who are vaccine hesitant.
Thank you, Ev. So now for our next polling question. What is the objective of the first elicit in the inform elicit strategy of motivational interviewing? Elicit what the individual plans to do with the information they have learned from your discussion. Elicit a positive emotion. Elicit a sense of fear of COVID-19, or elicit what the individual knows and ask permission to add to that knowledge. I'll give you just a moment. And most people got this right too, so we're doing our job. Yes, the last or the first elicit, it refers to eliciting what the individual knows and ask permission to add to that knowledge. So now I'm going to pass it over to Dr. Buchanan.
Thank you, Stephanie. Next slide. So we're going to follow up with some case scenarios. Just to be clear, that's not real cases, but cases that were made up to illustrate the challenges of advising women about vaccination during pregnancy. Next slide. So the first scenario is about Rosaline, who is 38-year-old. She's currently 12 weeks pregnant, and you're seeing her at her first pregnancy visit. When you ask her about COVID vaccine, she doesn't want to hear about it at all. Her husband and she are not vaccinated. However, she agrees to plan for influenza and pertussis vaccination. Of note, she is from an Asian background. BMI is 36. Finally, at the following visit, when she's 16 weeks, she explains that they do not trust the pharmaceutical companies and that the COVID-19 vaccine have been developed too quickly. Because of that, most of the people in our community are not vaccinated. And she says that she knows several people who have gotten COVID-19 and were not very sick. So she's not scary about the disease. Next slide, please. So in this kind of situation, we're going to go through a couple of suggestions to try to better advise Rosaline. So the first point, as Eve said, is to listen actively and to reflect where she is on the vaccine acceptance continuum. So for Rosaline, she's accepting some vaccines, but she's hesitant about the COVID-19 vaccine. You can also acknowledge the fact that getting vaccinated against influenza and pertussis during pregnancy is a good choice and will help to protect her and her baby against this disease. And then you can try to understand why and what make her confident that pertussis and influenza vaccine are okay, and why does she feel that she wants to take this vaccine. And you can try to build up upon these points to reflect the current knowledge about COVID-19 vaccine. So just to remember, her fear about COVID-19 was that they were developed too quickly. So it's really important to acknowledge that COVID-19 vaccines are really recent, that's true, but that the technology that they are built on was developed over years and used for other diseases before COVID-19. And also inform her that federal, provincial, and international regulation authorities have reviewed the safety and efficacy of this vaccine, which are still monitored. The last point I would make is about the cultural background. So just to remember, Rosaline is from an Asian community. And I think it's important to say the truth, and that in her community, vaccine hesitancy is more common, and that there is a variety of reasons about that. One of them is the history of unethical pharmaceutical studies that were done in these communities in the past. Also, the negative experience related to racism in this community can also be the reason why the vaccine hesitancy is more frequent. Maybe that's going to trigger the Rosaline to acknowledge that she had had this bad experience with the healthcare system in the past, and that maybe it's a bias in our assessment of vaccine in pregnancy. Also, I would suggest to validate that her concerns are natural and very reasonable. She wants to make the best choice for her baby, and that's really fair. The last one she made is that she knows a lot of people who had not severe form of COVID. So I think we need to help her identify a personal level of risk for COVID-19. She has several risk factors. So first of all, she is pregnant, but she is also obese and more than 35-year-old, and she's belonging to the Asian community. All of these are risk factors for severe COVID. So we should inform her that she has higher risk of severe COVID disease. And the last point to make is that if she is vaccinated, that would allow her to be vaccinated during the second and third trimester when the risk of complication is the highest. So at the end of the conversation, we should make sure that the patient, so Rosaline, has really understand the information that was shared and ask how she feels about it. If she has changed her mind, great. We can discuss an action plan about being vaccinated. And if she's still hesitant, it's fine. And I think it's important just to carry on the conversation at the next visit. As Eve said, it can take several discussions on vaccination during the pregnancy care to convince a woman. And that's very normal. So you can just refer her to some resources and go back to the conversation at the next visit. Next slide, please. So another scenario is Elise. She's 28 years old, 24 weeks pregnant. Her partner works outside the home as an electrician while she stays at home with her first child, who goes to daycare part-time. You see her with her partner. The current pregnancy was unplanned, but very well welcomed. The relationship between the two is really new, and the first baby was not with the same father. Since the partner is very anxious about the pregnancy and it's his first baby. Elise doesn't want to be vaccinated, neither for COVID or for influenza or pertussis, because she doesn't feel at risk as she stays at home most of the time and she doesn't see anybody. For instance, her partner does all the shopping and she's staying at home to keep the baby safe. She doesn't feel any anxiety or depression, but she's looking forward to the end of the pregnancy and to be able to go back to her normal life. Next slide, please. So in this situation with Elise, I think it would be important to go deeper into her point about vaccination. Did she get the flu vaccine outside of pregnancy? Was she vaccinated when she was a child? This kind of question to know where she's in the acceptance continuum. Then we should acknowledge that she's making a lot of sacrifice for her baby because she's staying at home. And we should express some concern about this isolation and ask her about social support and inform her that such isolation could increase her risk of perinatal depression. So make sure she has resources and doesn't have any more concern about that. So she said that she doesn't feel at risk, and it's important to inform her that the new variants of COVID-19 are highly transmissible, and most of the time there is no clear source of acquisition. Also, because her partner and her first child go to work or daycare, she's still in contact with the community and could be infected through them. Then I would ask her how she feels about the discussion and if she needs more information. If she has changed her mind, this is great. And if she's still unsure, that's okay too. We can think about this and move forward at the next visit. Because of this context of isolation and concern of the partner, I would try to call her or see her alone at the next appointment to make sure that the hesitancy is really her own, and also that she really has a choice to stay home and revisit her mental health well-being. Next slide, please. The last case is Jaya. She's 21 weeks pregnant, single mother. She had received 2 doses of COVID-19 vaccine in 2021 before being pregnant. She had a normal pregnancy until now, and second trimester ultrasound is normal. When you ask her about her third dose of vaccine, she says that she's still worried to expose the baby to the vaccine during pregnancy. So she planned to get the vaccine as soon as the baby is born to make sure the vaccine will protect the baby through her breast milk. So when you try to understand exactly her fears related to vaccine, she answers that she is worried about the potential impact of vaccine on the placenta. And she explained that her first baby was born small for gestational age because of placental insufficiency. So she feels that the COVID-19 vaccine could trigger the same problem again. Next slide, please. So once again, it's important to listen actively and identify where the Jaya is on the acceptance continuum. So she is fairly confident because she already has been vaccinated prior to pregnancy. Also acknowledge the fact that she's doing her best to make the right choice for the baby. Her previous experience of small for gestational age was scary, and it's normal that she's concerned when she heard that vaccine could impact the placenta. It's important to validate that for now the baby is going well, as shown by the ultrasound, and also to inform the patient, Jaya, that social media have carried on a lot of misinformation about vaccine impact on placenta. If she agrees, you can share with her some data about the vaccine safety in pregnancy, and there are actually a lot of really reassuring data on the impact of vaccine on infant growth and birth weight. We can also reflect that all other vaccines recommended in pregnancy have never been associated with growth restriction. So we know that for COVID-19, but for other vaccines. And the last point she made was about human milk. And it's important for her to understand that the placental transfer is really more effective than the human milk to protect the baby against COVID-19. We now have data to show that. At the end, we should verify that she had understood all the information that was provided and whether or not she feels differently. And once again, if she's still hesitant, we can follow up at the next appointment. But it's important to remind her that if she wants to make sure the baby is protected through the vaccination, it's important to be vaccinated at the end of the second trimester or really at the beginning of the third trimester to make sure there is enough time for our body to produce antibodies and protect the newborn. Next slide, please. So key takeaway from this scenario, vaccine hesitancy is complex and highly variable between individual and vaccine. So that's important to have open-ended follow-up questions and to really try to understand where the woman is on the acceptance continuum and what are her specific concerns. So the conversation should be tailored to this specific concern and the context, especially the social context of the woman. The conversation can go on several prenatal visits. And we should try to build trust with the patient through respectful, culturally appropriate communication.
Thank you so much, Dr. Bouquin, for your wonderful illustration of how to implement some of these techniques. It's really helpful. So now we're going to move to our question and answer period. So just to remind you that the the session will be taking place using the Q&A tab, which you should find at the bottom of your Zoom panel to the left of the chat. And just another reminder, I am seeing some questions coming up that are more clinical or technical in nature. So just a reminder that we have that webcast that has been posted in the chat to answer some of your specific questions about the safety and effectiveness of vaccines during pregnancy. So please take a look at that to answer some of those questions. We will not be addressing them today. You can like people's questions to push them up in priority, and we're going to answer as many as we can, but we might not get to all of them. So for the first question, this question is for Dr. Bouquin. If a client discloses that they are finding their information primarily from sources that are not evidence-based, how do you address this in a non-judgmental way?
I think my first point would be to try to acknowledge that vaccine is a very complex area, and that even for specialists like me, it's sometimes difficult to follow up and find the true data. And then I will bring up my suggestion, like what I feel are reliable sources of information.
Great. For our next question, this is for Dr. Dubé. Do you have any recommendations from a cultural sensitivity approach for addressing vaccine hesitancy in populations that historically have been tested on by the medical system, especially in the colonization context?
That's a good question, and my expertise is less with working with this group, but I've been doing research in Nunavik, northern Quebec, where Inuit population lives, and of course looking at around COVID-19 vaccine acceptance, and of course, because these populations were prioritized for COVID-19 due to their remoteness and lack of access to tertiary health care, there's been very specific challenges due to this idea that they were guinea pigs testing the vaccine prior to it being offered to the South. So I think it's really difficult to address all these issues within a specific campaign. It takes time to build trust and trusting relationship, and that's the key to an AIDS vaccine acceptance and uptake. We also know that there's some structural barriers in how vaccines can be delivered due to maybe a high rotation of staff in the north, that nurses are not maybe staying as long as they should be to develop trusting relationship with the communities. All those things are important to consider, and it's really a different context than what we're seeing elsewhere. And I think that colleagues from CANVax and the Public Health Agency have find some good resources that will be posted in the chat if you can have a look at it, as I'm not an expert in working with First Nation, Inuit, and Métis population, and of course there's really particular issue with that group.
Great, thank you for that answer. I'm actually going to jump to a question we got in the pre-registration questions when people signed up, because I thought it was really quite a good question. So this is for Dr. Boukouam. What is the best way to facilitate conversation between a pregnant person who is interested in the vaccine, but their spouse is opposed to it?
I saw this question also in the chat. So my bias is that the woman has the autonomy to choose by herself. So I would just remember the partner, that the pregnant woman has the right to do her own choice for her own health. And like we discussed the benefits of the vaccine for the newborn, but most of the benefits for vaccination during pregnancy related to COVID is the benefits for the woman's health, for herself. So I would also remind that to the partner.
Great, thank you for that response.
Okay. If I can add, Stephanie, I know that we often see it in childhood vaccination, where sometimes both parents do not have the same position on vaccination, and that could be quite emotional. And although I acknowledge that pregnant women have the right to make decisions with regards to their own body, I think it could be challenging and could be important as well to have this open discussion on values and emotion and why people are hesitant, because that could be getting worse. So if if the spouse is not willing during pregnancy, what will happen for childhood vaccination when the child is born? So that's an important question, and maybe it's a good time to start having those conversations in order to try to move towards vaccine acceptance.
Yeah, that's a great point. You know, this time is particularly good for shaping some of those conversations, which are going to come up around childhood immunization. So thank you for that insight as well. And I will address the next question to Dr. Boukouam. How can you address clients' concerns about receiving more than one vaccine at a time during pregnancy, such as getting the COVID vaccine and Tdap vaccine on the same day? How would you advise them?
So what I usually say is that we have a lot of experience on immunization with several vaccines at the same time. This is all we do childhood vaccination, for instance. But initially, when the COVID-19 vaccine have been implemented, just to be able to monitor the vaccine side effect, it was advised to have some washout period between COVID-19 vaccination, for instance, and pertussis vaccination. But that was not because of concern of efficacy. It was just to make sure we were able to monitor the side effect properly. So there is no concern of any type, like safety or efficacy, if we vaccinate the woman at the same time with influenza, COVID-19, and pertussis.
Great, thank you. And then I'd like to ask another question that came in from the pre-registration surveys, because I thought it was interesting. And this can be for either of you, Dr. Boukouam or Dr. Dubé. How do you mitigate misinformation that comes from other healthcare providers? So when a patient comes to you saying that they learned a piece of information from another physician or someone in their lives that they trust who's a healthcare provider.
That's a tough one, and I think that's really detrimental to vaccine confidence. We know that healthcare providers are considered expert in vaccination, even those who are maybe not really involved in providing vaccine. So giving advice that are in contradiction with current recommendation could have an important impact on vaccine confidence. And that's something that we need to address within public health, how to build trust among around vaccine among healthcare providers themselves, because we know that as with the public, there's some who are really, really pro-vaccine, and there's other who have different level of concern. But I'm really curious to know what Isabel is doing when she's facing that in her practice.
Especially for COVID-19 vaccine, I would also say that the information available on this have changed a lot. The recommendation have also changed very quickly. So I think it's very difficult for healthcare provider to keep up to date on this. I am lucky enough to be quite up to date because of my specialty in reproductive infectious disease. So I will also try to be not judgmental against my colleague, but just say that maybe they were not aware of this new data.
Yeah, that's a great way to frame it. It's very hard for healthcare providers to stay up to date. So that is all the time that we have for question and answer period today. So if we could advance the slides just to wrap things up, I want to thank our wonderful speakers for taking the time to answer our questions and provide this presentation. If we could go back, sorry, there should have been, can you go back two slides? On the topic of staying up to date. This is a great way to stay up to date. You can subscribe to the updates from the National Advisory Committee on Immunization and the Canadian Immunization Guide so that you get emails when there are changes to vaccine recommendations. Next slide, please. And there are more webinars and videos on COVID-19 vaccines that could answer a lot of the questions that you may not have had answered today. So you can find these on those websites. And then the last slide. So thank you all for joining us, and thank you to our speakers for coming today. We hope that the information provided will help you more confidently have conversations about vaccines with expecting families. We would like to thank all healthcare providers for your incredible work during this very long pandemic. So thank you so much for everything that you do. The recording and slides from today's webinar with clickable hyperlinks to all of the references will be made available on CANVax's website in the coming days. So for those who've been asking, that's where you will find those. And we ask that you please take time to fill out the short evaluation survey when you leave the webinar. These surveys are very important for evaluating our program and future planning. So thank you very much for taking the time to join us today, and we hope you have an excellent day.